From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
Hello and welcome to our listeners from around the world. I'm Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology Web Editor. Today, we're diving into the topic of screening for cognitive impairment, but not in the way you think. We'll be tackling this from the angle of artificial intelligence. Here to discuss his work titled Acoustic Analysis of Primary Care Patient-Clinician Conversations to Screen for Cognitive Impairment is Dr. Joseph Colonel. Dr. Colonel has a PhD in computer science from the Center of Digital Music at Queen Mary University of London. He is currently a postdoctoral research fellow at the Icahn School of Medicine at Mount Sinai Hospital in New York. His focus is on applications of machine learning and automated audio analysis to biomedical problems, including speech recognition and natural language processing. Dr. Colonel, welcome to the podcast today.
Thank you for having me.
Tell our listeners the inspiration behind your current study that you've performed with your colleagues. This is your wheelhouse. I understand that. So I'm sure there's a lot of excitement about this.
Yeah, so the original thrust of this project was intervening in primary care to screen for cognitive impairment, as cognitive impairment is frequently undiagnosed or underdiagnosed. And we believed that primary care is a great place of intervention for this screening. So generally, the idea was, are there patterns in a conversation between a patient and their physician that might indicate that there are some problems with cognition?
Yes, absolutely. And I think choosing primary care offices is actually a bright idea because a lot of patients who come in for memory complaints, cognitive difficulties, they may be seeing their primary physicians first. And the other thing I wanted to comment on is the amount of time that people may have. I like the idea of this because as physicians, we rarely have enough time for every chief complaint that's presented to us during the visit. So this idea of listening and picking up on these cues, I'm very interested on how this translates.
Exactly, yeah. So physicians in primary care are incredibly pressed for time. So our idea was, are there automated ways of being able to detect these indications of cognitive impairment from these recordings of dialogue between patient and clinician?
Was there prior work done in this space before you set up your study?
There's been a lot of research into screening for cognitive impairment for signs of dementia in spoken language. Frequently, however, that's happening with structured elicitation.
Mm-hmm.
So there's a good amount of research in machine learning for audio and for natural language processing that looks at recordings of participants undergoing a cookie theft picture description task and using the audio and the text to, derive prediction algorithms for their cognitive state.
Mm-hmm.
There's far less work that's gone into unstructured dialogue. So something that I really enjoy about this work is that there were no prompts given to the patient or the clinician. It was just, let's record a typical primary care interaction and see what we can find.
Right. I think that's definitely seamless on the side of the provider for this type of screening. Tell us about your study design.
We recruited older adults at the Mount Sinai Health System and the Northwestern Memorial Hospital System as well in Chicago. And we reached out to older adults who had an upcoming appointment with their primary care provider. And these were adults that did not have a prior diagnosis of mild cognitive impairment or dementia.
Okay.
The study is specifically looking at people with undiagnosed cognitive impairment, and participants were screened to ensure English language proficiency. But beyond that, it was just let's cast a wide net and see what we could find.
Okay. So the study participants all spoke English, and their chief complaint was not necessarily about cognitive impairment, nor were there any indicators in the chart that they had memory issues or cognitive difficulties.
That's correct. No one with a formal diagnosis of mild cognitive impairment or dementia was included in the study.
Okay. And then it looks like older adults, meaning age 55 and older, you have here, correct?
Yes.
Okay. And can you tell us about your primary outcome, and were there any scales used during the visit? For example, I know there were no props, but there was listening, and tell us about the further development of that.
Yeah. So to the best of my knowledge, the primary care interaction was recorded with a microphone on the doctor and a microphone on the patient. And then after that interaction, the participants were screened for cognitive impairment using the Montreal Cognitive Assessment.
Okay.
Yeah. The Montreal Cognitive Assessment was the screener given to all the participants. And in order to assess cognitive impairment, their raw scores on the Montreal Cognitive Assessment were normed according to age, sex, and education.
Okay. And then those results were compared to what you were looking at from the recordings, correct?
Exactly. Yep.
Tell us a little bit more about that process with the recordings, because to me, this is foreign. What exactly were the features that were involved, and just the details of what goes into listening cues and how those algorithms are created?
All of the analysis that we present is automated, and it's typically broken down into feature extraction, which is deriving these measures from the audio, and then the training of like the prediction algorithm, right? So I kind of think of them in two separate pieces. And in audio processing, and particularly for speech processing, there's these two paradigms for extracting features from the audio. There are traditional hand-engineered measures of the audio. So you could measure explicitly how loud is the recording, how long are the pauses, or how long is the duration of silence. These sorts of things, they come from signal processing tradition and people spending years and years deriving essentially what are equations to apply to the audio to extract some information about it. But there's also this new wave of features that you can extract from neural network foundation models. And we could clarify what that language means in a second. But essentially, neural networks and foundation models derive these features on their own. And the interrogation of these features is kind of challenging. We don't know what specifically they mean.
Okay.
But they've demonstrated very strong predictive performance across a whole, suite of questions that people are tackling.
So we have the recording, you're recording patients during the visit with their primary provider. And after that visit, these patients in the study are also filling out a MoCA, which is the Montreal Cognitive Assessment. And then this recording is being processed into a system that is creating paradigms based off of what you just explained to us. So it would be pauses and volume, intonation, things of that sort. And then the neuronal network is what connects those in order to determine what essentially would predict cognitive impairment. Am I on the right track there?
Close. I wouldn't use a term like neuronal network because I'm coming from, machine learning and AI and all that stuff.
Got it.
Let's just have a dialogue here, right? So we have, these long audio recordings, right? Some of these interactions are 30 minutes or so. And we divide them into 30-second windows, right? Just like portions of a conversation. We summarize those with these features, either the expert-defined ones or the ones that come from pre-trained neural networks. And those summaries are what are used to train machine learning algorithms. We used XGBoost, which is kind of like the field standard.
Okay.
So every 30 seconds, we get a prediction of the probability of the participant's cognitive status, and then we aggregate those over the course of the conversation. to come up with like a net prediction.
Excellent. That's pretty neat. So you were able to do this. You had 787 English-speaking participants. What were the demographics of those patients? I know they were above a certain age, male, female, things of that sort.
It was a diverse cohort of participants coming from urban settings.
Mm-hmm.
So there was a mix of white participants, Black and African American participants, Asian participants, as well as Hispanic participants.
So tell us about the results based off of the research paradigm that you have here.
So ultimately, the prediction algorithm was measured in 2 steps. The first thing we did is we measured its performance internally on the Mount Sinai cohort that we recruited. And after we developed the algorithm on that Mount Sinai cohort, we used the Northwestern cohort that we recruited as a holdout set. Generally speaking, you want to estimate how well your algorithm will work outside of your hospital system.
So that's like external validity, basically.
Exactly. Yep.
Okay.
So over the course of the development of the algorithm, we only looked at the Mount Sinai recordings and then applied that to Northwestern once everything was finalized. So internally testing on the Mount Sinai cohort, we were able to achieve an area under the receiver operator curve, which is like a typical ML metric of about like 0.73 on average, which is a relatively modest result. But in terms of the unstructured nature of our elicitation from participants, as well as just generally being a measure of behavior, I'm very proud of that number of what we were able to get there. And we saw a very similar performance metric on the Northwestern data, again, an AUROC on the order of 0.71, 0.72. AUROC stands for area under the receiver operator curve, and it's generally a measure of how well true positives and false positives distinguish themselves from one another at the output of one of these prediction algorithms. And the clinicians on our team wanted to take it one step further, and they wanted to see what it would look like if we developed a screening algorithm for cognitive impairment. And what that means is, given the output of this algorithm, if you're above a certain threshold, you would be flagged for cognitive impairment. And if you're below a certain threshold, you would be flagged for healthy cognition. So when we set our thresholds on the Mount Sinai cohort, I think we shot for sensitivity of about 80%, specificity on the order of like 20 to 30%, and a positive predictive value of 30%.
Okay.
And those numbers roughly translated to the Northwestern cohort, although sensitivity dropped and specificity raised a little bit.
Okay.
But we were able to maintain that positive predictive value of about like 30%. So in the results section under screening algorithm, there's like 2 numbers to present. The first is in the derivation set, which is like the Mount Sinai data that we have. We had a sensitivity of 83% and a specificity of 44% with a positive predictive value just below 30%. So there we fixed a threshold on the Mount Sinai data and looked at how it performed on the Northwestern data. And when we fixed that, the sensitivity dropped to 68%, the specificity raised to 60%. Yep. And the positive predictive value stayed constant at about 30%.
Okay. So that's very promising. So it looks like the models that you were using in both cohorts perform similarly. And it looks like there's positivity in terms of these models being used for screening and predicting cognitive impairment.
Yeah, it's certainly possible. The consistency of the AUROC metric that we have suggests that the separation of healthy cognition from cognitive impairment is relatively stable between the cohorts. The change in sensitivity and specificity would primarily be a calibration step that would have to take place in deciding when someone gets flagged for cognitive impairment or healthy cognition.
Right. Now, I'm going to connect this to the chair-side, bedside, so that our listeners can connect more with this data. So What is it exactly about the acoustic models that is being captured to help identify these patients with cognitive impairment? Because I would assume that when you did a study like this, there was dialogue with the clinicians, right? In terms of, okay, what is it exactly that this is picking up that's kind of the key in making this connection and helping decide, all right, if this occurs, then it's more likely cognitive impairment. If this occurs, we're on the normal scale, nothing to worry about for all intensive purposes.
Yeah, so this may be unsatisfying. Unfortunately, the answers were not entirely sure, primarily because our best performing model was using acoustic features from a neural network. And so because it's part of this new regime of ways to summarize this audio, we don't know specifically what is driving the performance of that model. We did take a look at our best performing model of these expert defined interpretable features. And that model was based off of prosodic features. So those relate to how someone talks, how does the pitch of their voice change, how does the volume of their voice change, how quickly are they speaking. Models trained using those features, just looking at the participants' audio, right? Just their contribution to the conversation. It had a much more modest predictive capability, so at a UROC of 0.6. But when we looked at what was driving those predictions, we found a couple of things. When we got under the hood and looked at the algorithm that was using these more understandable expert-defined features, we generally found that indications of rate of speech, so how quickly someone talks, the more quickly someone spoke, the more that was related to healthy cognition. And
Right.
things related to pause duration were more positively associated with cognitive impairment.
Okay. So that was one example of what you looked at. Was there anything about any measures on how loud the person was speaking, forcefully or soft voice, things of that sort? There are many neurologic problems that the voice is really an first indicator of what's happening with the patient or in the middle. So that's something that we may notice.
Yeah, absolutely. There were measures relating to energy in portions of the speech, either voiced or unvoiced, that were also related.
Very nice. Now, where do you see this going? What's the next step? I think it sounds like there are different parameters to work out and maybe additions to be made, but how would you improve upon your study results and make this more streamlined so that it can be used reliably at the bedside and chairside?
I think a natural extension of this work is pulling more of a participant's health record into the equation. So we're currently looking at incorporating electronic health records into this classification algorithm.
Mhm.
And on top of that as well, we're also beginning to look at the transcriptions of these conversations. So the work that we are presenting here doesn't transcribe what was spoken at all. We're just looking at the audio. So this is something that if there's a microphone in the room that is listening to this conversation, it would be able to develop this and predict this risk for cognitive impairment, sort of ready to go. But there are a lot of questions about the content of the conversation as well.
Right. Yeah. In our health system, we're using recordings to help with transcription and accuracy of notes. And I would imagine something like this, utilizing that content in addition to how the person is speaking, how they're answering questions. If I ask, what's today's date? What floor are you on? The pause and the uncertainty, intonation, all of that put together with the content, I think would be such a powerful addition to aiding us in pre-screening.
Exactly. Yeah. And I think AI scribes are a very interesting point of intervention here. If these tools are being used to assist these incredibly busy clinicians in transcription of notes, summarization of visits, whatever it may be, the algorithms that we are working on can just go right alongside those things.
If you were to pitch this to our listeners, anyone skeptical, what would you say about AI and aiding us in revolutionizing pre-screening for our patients, especially with difficult diagnoses?
I think there's a lot of very reasonable skepticism around AI and adoption. I think it's important for clinicians to remain on guard when some black box approach is being presented to them for, the integrity of their field and for the safety of their patients and for their responsibility in delivering care. I very much appreciate that. In terms of this project specifically, we looked at participants with undiagnosed cognitive impairment, and we found a prevalence of 20% after the screening and norming and thresholding and all those things.
Mm-hmm.
We found 20% of people going to primary care indicated signs of cognitive impairment. And that's a portion of the population that could benefit from earlier interventions, whether that's a pharmacological intervention or setting people up with community resources, whatever it may be. If this is an approach that can exist sort of as a fly on the wall and integrate into these tools that are meant to allow clinicians to be more present in their conversation, more attentive, and more accurate with the transcription and with the summarization, I think it's certainly worth considering.
Right. So not the end all be all, but something that will assist us in how we manage our patients and decide on different modalities of interventions as well as screening tools.
Absolutely. Yeah.
Dr. Colonel, thank you so much for joining us today on this podcast. I'm very excited by this work of you and your colleagues.
Thank you for having me. It's been a pleasure. I would like to give a huge thank you to the team that has worked on this, both in primary care and the AI department, psychiatry, genetics. It's been a tremendous effort, and it's been a real honor to be a part of this work.
I'm Dr. Cynthia Armand, and I've been speaking with Dr. Joseph Colonel about acoustic analysis of primary care patient-clinician conversations to screen for cognitive impairment. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.